Dr. Prakash Sanzgiri is one of my senior colleagues. We have both studied in KEM, GS Medical College, Mumbai, and he is one of the accomplished cardiologists and with a lot of experience in complex interventions, and has a variegated experience in all aspects of cardiology. He is attached to many hospitals, mainly Leelavati and PD Hinduja. So I would request Dr. Prakash Sanzgiri to please come over and talk on the latest 2021 consensus on impacting treatment choices in heart failure with preserved ejection fraction. Over to you, Dr. Prakash.
Thank you very much, Dr. Vijayan, for the kind introduction, and thank you, Dr. Mahapatra, for inviting me for this fantastic academic feast. The focus of my talk is going to be on ACC-2021 Consensus on treatment of heart failure with reduced ejection fraction. Now, this consensus guidelines give 10 pivotal issues, but time really does not permit me to address all those issues. I'll be basically talking on how to initiate, add, switch therapy depending upon GDMT, and how to achieve optimal therapy given multiple drugs for heart failure. I would like to begin with this excellent diagram which is there. On the left side, you can see that we talk about atherosclerotic risk, and the people in the very high risk group have approximately 6 to 7% risk of myocardial infarction or stroke over 1 year. On the right, however, you have those patients with heart failure, and you can see the risk is much more as compared to simple atherosclerotic vascular disease. And this is the reason that we need to focus and give guided therapy for these patients. Even those patients who are relatively so-called stable have a 10% 1 year risk of CV death or repeated heart failure hospitalization. And those people who have been admitted to the hospital with acute decompensated heart failure, the risk can be anywhere between 20 to 40%. One aspect we must stress at the beginning: stable heart failure is a myth. It is basically something which should be addressed at heart failure in remission. That is, the volcano is simmering and all you need is a trigger to erupt and cause acute decompensated heart failure. What about hospitalizations? We have this from the Trivandrum Heart Study and on the right from the Kyoto Congestive Heart Failure Study. Both these tell us that the cumulative mortality is much more if the patient is hospitalized again and again. And the more the hospitalization, the more is the chance of death, which is there. It can go up to 3 to 4-fold compared to only one hospitalization. So heart failure hospitalization should be avoided with the best appropriate therapy. Other aspect which we talk about is Indian patients get suboptimal therapy. Why is there suboptimal therapy? One is unawareness of the therapy amongst the doctors, inertia of prescription and adding new costly drugs, lack of patient education. How often do the patients tell us that I'm comfortable with the current treatment, so why costly drugs now? Yes, cost is the important factor, poor follow-up, adverse reaction, and also not initiating therapy before discharge. The question posed is, if this treatment was so important, why was it not started in the hospital? But what this, again, from the Trivandrum Heart Study has shown, that those people with guideline-directed medical therapy are much better than those who receive suboptimal therapy. So proper therapy is a must in heart failure patients. Now, this is again from the update, 2001 update, and it tells you how you manage heart failure with reduced ejection fraction. First and foremost, they say that ARNI AC inhibitor, ARB, with beta blocker is the first therapy to be started. To this, you can add on aldosterone antagonist, SGLT2 inhibitor, titrate the doses of diuretics. If the person has got renal failure, in India, you can switch over to hydrolysine isosorbate dinitrate and ivabradine to reduce the heart rate to less than 70. So let us go one by one to the first 4 therapy. What about ARNI? Sacubitril valsartan has been a game changer in the treatment of heart failure with reduced ejection fraction. How do you initiate the dose? If the patient is not on any ARB or AC inhibitors, you can start ARNI immediately. If the patient is on ARB, you can start ARNI immediately. But if the patient is on AC inhibitor, like ramipril or enalapril, you need to wean off the patient for 36 hours and then initiate the therapy. If the person is on a high dose of AC inhibitor, you can start with 100 milligram twice a day. If the person is on a lower dose, less than 10 milligram of enalapril or 5 milligram of ramipril, you start with 50 milligram twice a day. Subsequently, after 2 weeks, assess the tolerability, assess the blood pressure, assess the renal function and electrolytes, and modify the therapy and up titrate to a target dose of 200 milligram twice a day. So this is the way one would like to initiate ARNI, and the target dose, which is the best dose possible for helping the patient, should be achieved. What are the data which told us? Yes, the Paradigm HF told us that 20% reduction in the primary outcome of CV death or heart failure hospitalization for the patients who were given sacubitril valsartan versus enalapril. Prove It HF told us that NT-proBNP reduces at 12 months, and Evaluate HF told us that there is a good amount of echocardiographic modification in the parameters and benefits to the patient. So ARNI reduces CV death, ARNI reduces heart failure hospitalization, it benefits cardiac remodeling. The question is, does it translate into the need of CRT, ICD, or transcatheter mitral repair? We have anecdotal experiences, but no proven trials. So, ARNI should be the new approach. It should be the first drug to go to in all patients with heart failure, particularly those who are seriously ill. The reason is, if you start with AC inhibitor ARB and then titrate it to the maximum dose and don't get the benefit, a lot of time is lost. And this time is very important because you can see here that this particular study, the Pioneer HF study, that the initial phase, you can see enalapril versus sacubitril valsartan, there's a definite improvement in the mortality and repeated heart failure hospitalization. So the earlier you start ARNI, the best benefit will the patient develop. It is well tolerated in all cases, even with mild renal dysfunction. And it should be given irrespective, particularly if the eGFR is above 30. What about beta blockers? Beta blockers are the drugs of choice in heart failure with reduced ejection fraction. Way back in 80s, I remember starting on very minuscule doses of metoprolol for these patients, wondering whether they're going to land up into a florid pulmonary edema. But subsequently, it has been shown that initiation of beta blockers right at the time after the patient has been adequately diuresed beneficial. Which are the drugs which have been shown? Bisoprolol, carvedilol, metoprolol. Start at lower doses, hike up the doses until you reach the target doses. The Copernicus trial, CIBIS-2, MERIT-HF all have shown that they reduce the mortality. The all-cause mortality can be reduced up to 35%. That's huge. What about aldosterone antagonist? Again, various trials have shown that giving the patient aldosterone antagonist is beneficial, but there is a caveat to that. You can't give it if the eGFR is low. You can't give it if the creatinine is high and the potassium is high. So be careful when initiating, but keep on looking for the problems, keep on titrating as per the need. You can start with even 12.5 milligrams of spironolactone and up titrate the doses. What about SGLT2 inhibitors? Yes, SGLT2 inhibitors are beneficial. Multiple trials have shown that they are beneficial, but what is important is that ensure to it that if you're using DAPA, then the eGFR should be more than 30. If you're using EMPA, you can go as low as 20. But please understand that there may be some patients where you start the SGLT2 inhibitors, there can be initial drop in eGFR, but subsequent improvement and stabilization. Do not abruptly stop SGLT2 because the benefits of SGLT2 are enormous. They can be added as add-on therapy. It has been shown in the ACC-2021 guidelines as well as the European Society of Cardiology HFA guidelines that SGLT2 inhibitors are beneficial. DAPA-HF and EMPEROR-reduced study have given excellent benefit in these patients with heart failure. This is a very important slide. At what stage should you add the drugs? We are always concerned. If the blood pressure is low, the impact HF has shown we can start carvedilol, even if the blood pressure is just above 90. If the blood pressure is just above 100, Pioneer HF has shown that you can start ANI. Empagliflozin can be started. Sotagliflozin not available, it can be started. And if the BP is more than 110, transition has shown that ANI can be added. Now, what is important is all these trials have shown that the drugs which we are using can be initiated before the patient is discharged from the hospital. So, starting the patient on the drugs before discharge has the benefit of, number one, starting all the drugs together. Number two, under observation, one can titrate the doses, look for the side effect, look for the kidney function. And subsequently, since the patient is discharged on the drugs, the patient most of the times would continue the drugs rather than asking you, why now when I am stable? So this is the importance of starting pre-discharge drugs and continuing them for post-discharge for a longer period of time. This is a very important slide which shows that if you start these drugs initially, you can get a significant reduction in all these parameters: CV death, heart failure, hospitalization, death, or all these parameters. The benefits which you get with the 4 pillars of GDMT within 30 days of initiation are enormous and can reduce the morbidity, mortality, and also heart failure, hospitalization, improve the quality of life. So starting them early and up-titrating them as early as possible is the best outcome. Coming back to my initial slide, how can we reduce this high mortality? Yes, the 4 drugs, ANI, beta blockers, SGLT2, and MRA, all reduce sudden death, reduce ventricular arrhythmias, ICD shocks. They will definitely benefit the patient and reduce cardiovascular mortality, which is a major problem in all patients who present to you with heart failure with reduced action. The real challenge is prescribing the right drug to the right patient at the right time. This is the gist of my talk today. The story is not over as yet in this war against heart failure. It can only be won with pragmatic, deliberate, and scientific implementation of data, which is forthcoming every day, and also overcoming the inertia of prescription, which is related sometimes to the fear of prescribing a new drug, sometimes to the cost of prescribing the new drug. The quadruple therapy is the new standard of care for heart failure with reduced ejection fraction, beta blockers, ANI, SGLT2 inhibitors, MRA, with subsequent add-on titration of diuretics, with add-on of ivabradine, and all the other drugs, like all the other therapies like CRT, ICD, will definitely reduce morbidity and mortality of heart failure. Thank you very much for your attention.